I'm joined in this session on legal, ethical, and equity considerations by Dr. Monica Peak, who's professor of medicine at the University of Chicago, by Jennifer Piatt, deputy director of the Network for Public Health Law, the Western Region Office, and Dr. Matt Winia, who is director of the University of Colorado's Center for Bioethics and Humanities. So we'll start off with a presentation, first by Jennifer Piatt and then by Monica Peak. So Jennifer, take it away.
Thanks, Eric. Thanks again to all of our audience members for joining us today to discuss in our final workshop what we've uncovered during this series. Now, I briefly want to pinpoint the precise workshop that we'll be discussing along with my great subcommittee colleagues, Dr. Monica Peak and Dr. Matt Winia. That workshop helped to pinpoint the legal, ethical, and equity considerations in crisis standards of care. The primary considerations involved in that workshop involved first discussions of the legal challenges and opportunities pertaining to liability protections in CSC, and second, the incorporation of ethical and equity considerations in the allocation of scarce resources. So I'm going to start off by taking on some of the legal considerations, and then I'll turn it over to Dr. Peak, who will take us through the ethical discussion. Next slide. So first, with respect to CSC and liability protections, which should help to implement it, a primary consideration are the two distinct pathways which might be utilized to provide these protections in emergencies. The first pathway involves following the standard of care, which evolves with circumstances. Under this consideration, the standard itself should shift to that crisis standard, potentially making additional liability protections unnecessary. But there are distinct concerns illustrated by this pathway. First, it becomes extremely difficult to assess after the fact exactly where a particular standard fell in a particular location at a particular point in time. It's effectively a moving target. Additionally, there's potential for courts to come out with differing or conflicting interpretations on that applicable standard, especially without uniformity, which is, as we've heard today again and again, a continuing issue in planning for and implementing CSC. State plans, local plans, individual hospital plans differ. That complicates identification of where the standard truly lies. Now, the second pathway relies on making available express liability protections to offer immunity from ordinary negligence in emergencies. This pathway may provide more comfort as distinct protections are expressly laid out in law or other sources, but there are still questions to be answered along this pathway. For example, questions surrounding the duration of those protections or the scope of immunity that they actually provide. Protections may only last during an emergency declaration or a specific period of time and may protect quite specific persons or behaviors. And I want to give just one brief example to help illustrate these questions. Next slide, please. So take two distinct legal sources for liability protection at the federal level that arose during the COVID-19 pandemic. The CARES Act provided express liability protections for interstate volunteer healthcare workers, not extending to willful or criminal conduct. Contrast this with the Federal PrEP Act declaration, which provides immunity beyond volunteers to any defined covered individual or entity against claims of loss resulting from covered countermeasures during the emergency. This too does not cover willful misconduct, but it's easy to see, through just considering these two distinct sources, how different liability protections can cover different actions during emergencies. Additional protections differ at the state level across a number of jurisdictions. And this umbrella of protections can be large and complicated across those jurisdictional boundaries, while COVID-19 and other potential future emergencies cross those boundaries indiscriminately. Additional research may help to ensure that these protections are not only incentivizing healthcare workers' service during emergencies, but also CSC implementation itself during emergencies. And legal actions should additionally be taken to ensure additional load balancing hand in hand with establishing these liability protections. That's necessary to address the emergency uniformly and consistently across different facilities and jurisdictions. Next slide, please. So the second area I'd like to just briefly summarize on the legal side involves, again, making those difficult allocation decisions lawfully during emergencies. HHS's Office for Civil Rights helped to illustrate red, yellow, and green light scenarios for considerations included in triage plans. Now, the green light scenario, or the best practice, involves determinations based on individualized assessments of each patient, the best medical evidence available concerning the likelihood of death prior to or immediately after hospital discharge. But what are those permissible and impermissible bases available for making difficult allocation decisions? Next slide. The list continues to evolve, but for the moment it looks something like this. Clearly impermissible bases involve categorical exclusions based on protected criteria, disability, race, sex, religion, etc. Eliminating these kinds of legally prohibited allocation bases still leaves room for considering additional bases in green below, but the list should be considered evolving and one which can change as additional evidence arises to illustrate additional disparate impacts. CSC plans have to go beyond identifying express discrimination and eliminating it, to addressing those issues which perpetuate systemic inequities. Like, for example, much of the work identifying inequities and using the SOFA scoring metric. There's certainly a long way to go here. Planning must be deliberate in its efforts to address resulting disparities. Now, with that, I will turn it over to Dr. Peak to take us through some of the ethical considerations.
Great, thank you so much, Jennifer. And so what I'd like to do is transition, like you said, from the explicitly legal to thinking more about the explicitly ethical issues with a lens towards equity. And obviously there's a continuum and a transition between these two. And many of the points I'll highlight are a reflection of the things that Jennifer was just talking about. Next slide. So what I'm going to do is try and recap what was said in our official panel that was just from our workshop 2 weeks ago that was led by Govind Prasad, assistant professor at Sturman College of Law. And then we had some panelists who were responding. So Virginia Brown, Nkika Setterstorm, and Thomas Sequist from Mass General. Next slide. So the large question that we have here with our crisis standards of care are really, can we align multiple different goals? Can we try to, multiple different ethical goals? Can we try to prevent harm, as in death, loss of time of alive, extend your life years, reduce the chances of illness, social disruption, quality of life, loss of children's caregivers, etc. Can we treat people with equal concern? And most importantly, or maybe not most importantly, but as an equal consideration, can we mitigate health disparities? And so for those who have been facing structural disadvantage, as Jennifer was just talking about, and Anush and others, how do we, as a society, take into consideration there are those whose lives have been harmed over time by the policies, procedures, and norms in our society that have put them at a disadvantage. So they come into our health systems with an extra burden of dishealth and disease. And how do we account for that from an ethical perspective? Are these people then additionally burdened by saying that we're going to discredit your chances of having these additional resources that might be life-saving? And so how do we mitigate additional health inequities by having systems that can sort of take into consideration the structural disadvantage that these populations have already had, and don't exacerbate disparities? So that's the challenge that we have in front of us, and ones that crisis standards of care have not historically tackled head on. and have not necessarily done so, as alluded previously, in conjunction with community-based organizations, so that there's a lot of transparency, so that there is full input, so that there is a sense of ownership over, a co-ownership over the process, and full buy-in over the results once they are available, and that everyone is then on the same page about the implementation plans, because that's where the rubber hits the road. And if they don't have full buy-in, then we'll see a lot of pushback, which is what we've seen during the pandemic. Next slide. So we've seen some research that has shown some opportunities for goal alignment. So for example, within the ICU, as Jennifer had alluded to, some of the work around SOFA scores, which has been sort of a newer area of research that I've been fortunate to be a part of some of that work, that has shown that age-aware approaches prevent more deaths, so thinking about harm, and better mitigate racial inequities. And so thinking of those three goals, harm and mitigating health equities, than just using SOFA alone. So there we have one strategy that is better at getting two of our goals than a different strategy. So age versus just using SOFA alone. When we think about the distribution of COVID vaccines, we find that rather than only using age, we add that to a measure of social vulnerability, like the Social Vulnerability Index, then those two are better at preventing, again, two of those three things, preventing harm and mitigating inequity, than using age alone. So we're starting to have more information about how we can think about aligning these principles in ways that can allow us to meet more of our goals of not just thinking about mitigating inequity or thinking about harm reduction or thinking about lives saved, but doing so in a complementary fashion that we can get more than one goal achieved at the same time. Next slide. So this is again referencing what Jennifer was talking about as far as allowed categories within the CSC. And so there are some, the ones that are in red are the ones that we are not legally allowed to consider, sex, gender, individual, race, and others. Ones that we are allowed to consider are things that are health measures, societal vulnerability like SBI, which includes race at the group level or the neighborhood level. And then things that are sort of in play, specific health conditions, vaccination status, and age. And so during our workshop, we actually had a lot of conversation specifically around race. Next slide. Because of the significant impact of racial health disparities during our pandemic. We've seen a lot of disparities in multiple different marginalized populations, but it was the racial health disparities that really had the largest signal and took everyone's breath away as far as the headlines. And so there's a lot of robust conversation in that workshop about how to think about addressing those the most effectively, the most holistically, the most comprehensively. And is that done by thinking about individual race, which is currently not legally allowed, or thinking about group level race, which you can do when you think about structural disadvantage, like SBI allows for group level race. And doing so, that framework means a change, a shift into thinking more about racism, structural inequities, rather than race as it applies to the individual person. And there's a conversation about, should we be working exclusively within our legal constraints? Right now, that is the assumption that everyone is making, but we have to take a more, at least think about a longer historical narrative where we understand that laws are not always just, and that it has been part of our country's history to push back against laws that may not be fair. Many of those laws have been specifically unfair for racial and ethnic minorities. And so we might find the most justice by pushing back against the laws that say we are not allowed to use race in this way in order to fully capture racial equity. Because when we look at models, when we do the math, when we try and use systems that account for structural disadvantage, there's still some residual reckoning that we can't get right around COVID and race. And so how are we best able to think about mitigating health disparities if we're only looking at some of the mechanisms through which racism, structural racism, and interpersonal racism occurs? So, so that is a lot of what we were talking about when we're thinking about allocation of scarce resources. And the kinds of resources that we allocate are, multiple and varied. We have tended to think about those things in the ICU, ventilators, but we're expanding our repertoire to think about people in the ICU, as well as monoclonal antibodies that are used outside of the ICU and hospital system, obviously vaccinations. But one of the last things that has been particularly prevalent throughout this workshop series is thinking about hospital transfer systems, and particularly its role in mitigating inequities, and that being sort of the most important next frontier for us to try and the challenge for us for as we think about trying to mitigate health inequities, and thinking about the load balance, not at the state level, but at the microcosms within communities, and the disproportionate allocation of community resources for small hospitals, which tend to be, Black serving institutions or brown serving institutions versus white serving institutions that have more resources, are more likely to be tertiary care hospitals, and how can we establish transfer systems that may require the state government stepping in, as it has in several states, to try and forcibly promote equity. And so with that, I will stop and I think just make sure that's my last slide. Yes. Okay. So I'll stop and invite the rest of our panelists to join us.
Thank you, Monica and Matt. Welcome to the panel. And I think I'll start with you and ask you what you've heard today, what we heard in the last webinar on this topic, or what you've seen throughout the pandemic that comports with what your previous notions have been around crisis standards of care, and what has surprised you.
Yeah, and I have to admit, I've been taking notes, and I have at least an hour's worth of thoughts on this. So I'm going to struggle to say, I'll pick a few things and hope not to be too redundant also to what others have said, because I think we've covered an enormous amount of ground today. I, over the last weekend, had the opportunity to look back at a chapter that I was working on when the pandemic came. We had just turned in our final draft of this chapter on ethical considerations in outbreaks and pandemics for a book that Trish Pearl is putting together. And of course, the book was, set aside because it suddenly became outdated. But I went back to look at that chapter to see, well, what would it take to update this chapter? And it was a little telling because, in fact, many of the things that we've experienced during this pandemic, we expected, but not to be as bad as they were, right? So these are things we knew would be problems, but we didn't know the extent to which they were going to actually come into play. So the critical importance of load balancing as a mechanism to avoid having to go into crisis standards of care. So early on in New York, very early in the pandemic, maybe it was excusable that we had hospitals that had beds available that were 6 blocks away from hospitals that were completely swamped. Maybe you could excuse that. But just a few months ago, we had, stories out of Texas where a young man died of a perfectly curable illness because they couldn't find a place to transfer him in to get higher levels of care than where he was located. That is completely inexcusable. So this problem of load balancing is really very top of mind. And we knew it would be a problem. It's always kind of a problem, but the duration of this pandemic, we really should have figured that out by now. Second thing, I think very important, we knew that there would be some reticence to acknowledge that you were entering crisis standards of care and that you as an institution, as a state, were no longer able to provide adequate services to your population. We did not know how very reticent some institutions, states would be to acknowledge how bad things are. It has become very clear, and this has been repeated throughout this series, by the time places are in crisis, are declaring, authorizing, activating crisis standards of care, they've been in crisis standards of care often for weeks, if not even months. And we're experiencing this today in Colorado, where we have declared crisis standards of care for certain things, but we're doing stuff right now that is quite risky. And we're doing it without the kinds of legal protections that crisis standards of care ostensibly provide. Again, one more, which is the role of factors like race, age, socioeconomic status. These are almost uniformly put at the front of crisis standards of care documents to say we don't use those. And yet, as we have moved along through the pandemic, it's become increasingly clear that sometimes we do have to use those things. And I'll just give you one example. When we were talking only about ventilator allocation early on in the pandemic, and we were really worried we were going to run out of ventilators, our focus was very much on who's going to die even if we give them a ventilator. And for a decision like that, it seems legitimate to say, we don't care about long-term survival. We just want to look at, at short-term. We don't want to look at race. We don't want to look at insurance status. We don't want to look at socioeconomic status. Well, at this point in the pandemic, we're really looking for who can we discharge from the hospital, whom we normally would keep, but that person doesn't necessarily need hospital-level care. Well, now you have to take into account socioeconomic status and social supports, right? Because otherwise, if you tried to make just a criterion that looked only at clinical status, only at clinical factors, you would end up discharging from the hospital someone who has no social supports and no capacity for home care and, poor insurance coverage, et cetera, and keeping in the hospital maybe someone else who, has clinical criteria that make them need to stay in the hospital perhaps, but they could very easily afford to have home nursing and telemedicine and all of the home supports that would allow them to be safe at home. So we once we're not talking about ICU care, but we're talking about who can we get out of the hospital more or less safely, we have to start looking at things that we initially said should not even be considered in making these decisions. So these issues, I think, are fascinating and important. I'll give age as another criterion here. We don't want to look explicitly at age, but as we've gone along, we've realized what a powerful predictor it is, even after accounting for all of the comorbidities that come along with age. Age per se is a quite strong predictor. Should you go ahead and use it? Well, when we used age to allocate vaccines, we got very little pushback. Elderly people were happy to be first in line for vaccines. When we want to put age explicitly into ICU or other allocation criteria, we immediately get pushback. Elderly people and the communities that support them, I'll even put myself in that category, are very reticent to have age explicitly being used for ICU allocation, but we're happy to see it being used for vaccination allocation. So I think we have within us tensions about how best to use these kinds of criteria. So I'll stop there because I know
Well, thanks, Matt. Your timing is excellent. We just ran out of time, as you said, your last few words. So very, very interesting comments and provocative. A lot to think about. So we must move on, though, into our next and final session.